topic of discussion today will be breaking bad news. So those of you who are directly in healthcare and also directly involved in patient care, what challenges do you see in breaking bad news? If you may share your experience. So even if you're not a clinician, at least you are involved in the management, and I'm sure you must be seeing the impact of breaking bad news. If you would like to.
Yeah, I can share a few points that one of the challenges that come is when the patient and relatives are not regularly updated about the progress. So at times it becomes very late when the first actual communication happens regarding the poor prognosis or the guarded prognosis. So that is one challenge, and it ultimately leads to non-acceptance or denial from the patients and the relatives side. So timing, I think, is more crucial on at which point you communicate the bad news and what happened before that.
I completely agree with you. If you haven't done any preparation, if you have not prognosticated about the patient's condition or deterioration or poor prognosis, then there's always a risk of denial and allegation of improper care and not being attended properly. I understand completely. Anybody else who would like to share their understanding or their experience with challenges in breaking bad news? Ma'am, please unmute yourself, Dr. Tanu.
It is difficult to tell the relatives, especially if it is not anticipated. Like if it is anticipated, then over the days you can tell them, okay, the patient is worsening or his parameters are declining. But if it is a sudden thing, then it is very difficult to explain, especially if it's a dead baby born or a sudden event. Sometimes it happens that patient is improving and suddenly something happens and patient deteriorates or dies. Then it is extremely difficult to explain what happened.
Absolutely.
So those are the issues that are...
Especially when you are not expecting something like this.
Yeah. And third thing is when it's a patient who is going to stay with you for a long time. Like I mentioned in my mail also, like preterm babies and all who stay in the nursery for long times. So, you know, that sustaining that hope and because, you know, there is these, they improve, they deteriorate, they improve, they deteriorate. So maintaining that hope and faith is very difficult in those situations.
Absolutely. I completely agree with you. So, Amreen, you have been in direct patient handling. So what has been your experience? Amreen, if you're comfortable having your camera on and talking to us. Amreen, we're not able to hear you. I think there's a major network issue at your end.
Yes, and that's why I got late also. I'm trying to sort that out.
Okay. So it's okay. Take your time. Take your time. That's all right. So anybody else who would like to talk about their experience or their challenge in...
Breaking bad news, of course, is difficult where patient passes away very unexpectedly, code blue kind of situation also. But then the problem could happen where the relatives get aggressive. So it's breaking bad news and then dealing with aggressive relatives later, which could cause a code gray kind of a situation.
Absolutely. I completely agree with you. So I think breaking bad news is one of the most challenging communication. And we all know Nobody gets a formal training in breaking bad news. So everybody does it the way they like to do it. Some of us are very effective in doing it. Some of us even know that before I break the bad news, I need to do some, prior work to breaking bad news. But many of us would just go out and, tell the patient or the family, this is what it is. And then there are repercussions, like they become aggressive, or they may deny, or they may, they may be very, very unhappy. They may even allege negligence, even to the extent that they may take us to court, just because we haven't been able to deal, effectively with the situation, and we haven't done our homework well with this. So I was interacting with the CMO of All India Medical Institute, Delhi. So he was CMO for good 5 years. So I just asked him, and we were quite friendly. So I asked in a very casual way. I said, how many times have you experienced violence, or somebody hitting you, or literally, becoming physically aggressive with you? He said, not even once. I was really shocked. I said, how come? Like, every day we hear something or the other from each hospital, where, especially in casualty, emergency care, where people become very aggressive. He said, the moment there is a patient in critical condition, and we know that this is a patient probably will not make it. So one team will be working on the, patient, in settling the, stabilizing the patient. But I would always go and start talking to the family right away. I would actually, first of all, understand their point of view. Then I'll explain them what is the condition, what is happening with the patient right now, what we are doing, and what is the possibility of, improving or survival. So he says that way they would normally get prepared for the eventuality. So even like normally people say in emergency care, it's very difficult to break bad news because you haven't had enough time to build rapport, or to build their trust, or at least, take them into confidence. But this CMO, he said that I would not wait to hear from my patient, because we would have an idea what is the patient's condition or what is the likelihood. But at least I'll have my, dialogue open with the family. I would immediately go and talk to them, ask them, क्या हुआ, कैसे हुआ, इससे पहले कहाँ ले गए थे, यहाँ कब लाए, कितना time लगा. So in a way, they will kind of become familiar with the CMO, and then they'll open up also. He said, I could also see who all I need to interact with, because you can see some people who are dominating the conversation. So probably they are the primary caretaker, or they are the primary influencer, or immediate family member. So I would be able to identify also from their body language and from their clothing and all other things. I would know what kind of family they are, what kind of, behavior they may, give us when we break the bad news. But the idea was that he said I would always kind of, create a dialogue with them, so that if I need to go and tell them that this is what has happened, so they will know, okay, you had already informed us. So it was a big learning for me. I said that means even in emergency care, where you don't know the prognosis, but then at least having a dialogue, creating a, interaction is very, very important. And and he said, never I have had a situation where family would allege me for the negligence, because we do whatever we can do. But what happens is we don't communicate to them. So you don't only have to look after the patient, but you have to also communicate to the family what is being done. So normally we do everything for the patient, and we think telling the family is not necessary, or we can talk about it later. But when we are not communicating to them, they don't know what is the condition, what is being done. They will be seeing the patient lying down, but they don't know that we have already sent the blood sample, we are arranging for blood, we have already started IV, we have called the specialist for examination, X-ray is being planned, or CT is being planned, and everything is like happening. So he said he would always communicate, okay, this is where we are, this is what is being done, and then also what is the likely outcome. But of course, breaking bad news is one of the most difficult communication. So before we move, should we do a small, experience session? So what I would like to do, that I will be dividing you all in two groups, because you are 10 of you. So I'll divide you in two groups. And one of you will have to role play the role of a doctor who will be breaking the bad news. The second one will be the patient, and then the relatives. So, of course, the person who wants to be the doctor will have to play the role of a doctor, like where you have to communicate. And I'll give you a case. I'll give you a small situation. Take this, that your patient is a young, male or female, and has been diagnosed with CA pancreas. I mean, that's sure. You are confirmed that it is a CA pancreas, and you have to break this news to the patient. Plus, there is family. It could be the parents, it could be brothers and sisters, it could be wife or husband or anybody. So try to get into the role. Although I know role play is not like you can actually get into a real life experience, but then it takes you quite close to the situation. Try to think of the feelings of body language or whatever you think would be the impact of the communication. And also, the person who is playing the role of a doctor, try to see if you had to actually do it, how would you feel? What do you think will be his or her concerns? What would be the challenges of that person? And the family can behave the way like family would usually behave. Sometimes they feel not enough has been done, or they may think that our our complaints and requests were not taken seriously, and there was unnecessary delay in the treatment, which we usually get to hear, that we were made to come so many times and you did not do the test on time. This ultrasound and CT could have been done on the first or the second visit. Why did you wait for so long? And then you called us after every 1 week. You could have called us the very next day. So, I mean, these are the usual things you would get to hear from patients. So family can behave the way they like. And then just try to get into the role. The idea is I want you to have an experience. So in total, I'll be giving you, is 5 minutes okay? Or you think you need more time? 10 minutes? Because you will have to first identify. So don't waste much time in identify. Quickly decide, okay, who will be the doctor, who will be the patient, and who will be the family. Try to practice it. And then I'll ask one of the groups to, do the role play for all of us so that we can see it happening. So it's more like practice session. You get 10 minutes and then 5 minutes of performance. Any questions about it?
No.
Okay, so I'm just randomly putting all of you in breakout room. So I'm going to create 2 breakout rooms, and I'm not assigning, it's assigning automatically. So there you go. So you need to press that button of joining. Yeah. So Sharvano, you need to press that button of joining so that Sharvano, are you there?
It was like reliving few moments for me. Oh,
Especially those of you who have been in a similar situation. It must have been
yes, my
very
mother was suffering from cancer, so it was like reliving those moments.
I completely understand. Okay. So I got into both the rooms and I saw the role plays was being done very seriously, very effectively. I want to understand from those who played the role of doctor, what challenge did you experience or what was your concern at that moment? One by one. I think Dr. Kunal and Dr. Tanu were playing the role of the doctors. So I would like to know from both of you one by one. So Dr. Kunal, you may start.
From a doctor's point of view, it was difficult to share, considering the patient to be of a young age and accompanied by the family members.
Mm-hmm.
And well, when we are revealing it together for the first time,
Mm-hmm.
so neither the patient nor the relatives were knowing it beforehand.
Mm-hmm.
So that was the difficult part. The questions where one of the relatives were focused more on the treatment part, one of the relatives was focused on the cost part of it, and the patient was worried about her family members and her kids. So multiple questions at different levels of were put together in the same conversation. So that was difficult to focus on whether to focus on which part while discussing it, and whether we will be able to justify all the relatives or whether we should focus only on the patient or what the patient is trying to say. That was one of the challenging part that I felt.
Absolutely. And what was the feeling inside about, if you had to actually do it in real life situation? What about your confidence or your ability to handle the situation?
I felt that I could do it well if it was a real life situation. What I would require more than what I had today would be the options of the further plan of management, so that I would be better prepared and guide them to what is going to happen next, rather than focusing too much or blaming themselves for being late or anyone else.
Very true. Very true. So, Dr. Tanu, if you would like to share your experience.
So, of course, the first thing is simply saying out the words that he has a cancer. The saying it out is the difficult part.
Absolutely.
Because this actually, it's like a bombshell. And then as a service provider, the difficult part is when you tell them that, when they say that he has been coming to you for some time, why didn't you refer him straight away? So explaining, like in this case, I was referring the case. So why the specialist was not called straight away, or why patient was not referred straight away. And that was the difficult part. And like Dr. Kunal said, it's important to know the plan of action, a little more about the disease itself, how it progresses and all, to be able to communicate more effectively with the patient. So usually one would talk to the treating doctor usually to know a little more about it. Yeah.
So maybe before we actually go and share the diagnosis to the patient, we need to discuss with our colleagues and find out from them who is joining now. Somebody has joined with the iPhone. Could you please rename?
Good evening, madam. This is me. After a few weeks, I came in again. I was so busy. Right now, I arrived home and I break my fast and I joined the meeting.
Thank you. So, saying that you have cancer is not a small thing. I completely agree. And second, when we are going to break the bad news, it's very important to have all the information, and especially like when the patient says, am I going to live? How long is my life? What is going to be the quality of my life? Somebody was asking about the expenditure. And they're all very pertinent questions. Where are you going to refer me? What other options do I have? Which is the best center or which is the best doctor? Is chemo the only way? Is surgery the only way? Can we try homeopathy? So all these kind of questions a clinician is going to be asked when the clinician breaks the bad news. So just going and telling that you have this is not going to be enough. You really need to do a lot of homework, and you can actually, try to see what questions the patient and the family may have, and be ready with some answers that would satisfy them, or at least give them some direction in a real sense. So if I may ask the patients now who played the role of patient, what was your feeling when you played the role of the patient? I think in this case, Pritaji, you were there in one of the groups. Yeah.
So I think when you are the patient and you are getting to know that you have cancer, I think first is you're stunned. You're shocked beyond belief.
Absolutely.
You are wondering whether what you're hoping, what you're hearing is false. And first thing you fear is, what if something happens to me, then my family? That is, as a woman, that was my first fear. So that's what I was asking. Kuch bhi karke mujhe isme se nikale. I have 2 children. And am I going to die? That was my first thing, because I was only bothered about that.
You were really playing the role of the patient very well, and you got into that role. I could see your
Thank you, ma'am.
expressions, and your questions were very pertinent, like a patient.
Thank you, ma'am.
Well done. Well done. So I think in the other group, Dr. Arjun, you were the patient?
No, actually, patient brother. In our group, the patient wasn't there.
Okay.
I just wanted to know, like initially, to break bad news, is it a good idea to have the patient in the conversation, or with just the patient relatives first?
So again, it depends. See, in our country, we normally speak to the family first.
Right. Okay.
Because they are the caretakers and they are the one who are decision makers. Patient is usually a passive participant. But we also know that if we look at the patient's rights from the legal point of view, it's patient's information, and we cannot actually share with anyone without his or her permission. So this dilemma.
Even to close family members, huh? Even to the close family members?
Yeah. Legally, we are not supposed to be sharing the patient's information without patient's consent with the family members. But this dilemma, I think we will continue facing till we have a clear verdict on it, because theoretically, it's the patient who should be knowing first, and we have to actually ask, do you want me to share this information with your family or not? But in reality, it's absolutely opposite. We normally talk to the family first, except certain conditions. For example, you may have seen when patient is HIV positive, you would always speak to the patient first, because although you need to inform the family, even if the patient says, please don't tell my family, because the family is at risk, especially the spouse is at risk. So it's your duty to inform the family member. I think we read a case, I think good 4 or 5 years ago, that a very well-known personality was diagnosed with HIV positive, and he refused to share this with his spouse or his fiancée. And but the doctors knew that if we don't inform the partner, then she is likely to get infected. They informed her, and then there was a big
legal case about
legal battle. Yeah, legal battle. But those are
but there was a case against the hospital that why they shared. But
Yeah.
I think court ruled in favor of the hospital.
Yes, because there are exceptions, and it clearly says if there is a risk to family and society, then you don't have to follow this. Even when we do counseling, as a initial this thing, we always say, whatever you share with me, we are not going to share with anybody. You can be, very, very sure of it, that not even with your family we are going to share. So you can talk to me anything, except in two conditions. One, if you are going to harm yourself, or there is a likely harm to anybody around you. If you're suicidal or homicidal, then I think it's important to inform you. Then we break this rule. But we announce it right in the beginning. We announce. Is that your grandson?
I think granddaughter.
Oh, so
She's
cute.
very cute.
For a minute, I thought it's a doll around you. Hi, baby. Oh, good. So cute. So she's compensating for your absence by having two participants in one go. Okay. So what I was trying to say, breaking bad news is definitely challenging. What about the family members? If quickly one or two of you could share your thoughts about how did you feel being the relative of a patient? Especially like Savita ji said that for her it was living those moments.
So
Yeah.
it was as just like the patient, even the relatives also, you are it takes a little time to process, and then you don't know like what is important, what do you need to ask first. So for me, I was and it was the same thing, like actually how it happened in my personal life. For me, it was like we all know that treating cancer is not a cheap option. So, but then it was like, between the two, cost and treatment, what is important for me? So, for me, it was like that, my mother should be treated at any cost. So I didn't think about cost. So for me, it was like, okay, now that this has been there, what needs to be done? So for me, getting into the action, and enough time has already been lost through not because of wasting of time, but then, the diagnosis and the kind of tests and all that have taken place. So I didn't want to lose another moment. So what can be done as early as possible, and have a clarity on that. So for me, it was all about to getting to action. And my response was absolutely the way it was with my mother. So didn't think of anything else. So it was like, okay, fine. So now let us get to the task at hand.
I get your point.
But I think, it's this depends on the person to person, the way we react.
I was about to say that.
Yeah.
Now, if like we have 10, 12 people here, if I may ask you one by one, like what are their usual concerns, which sometimes we do not handle effectively? For example, Pritaji asked this question, how long am I going to live? So very rightly, Dr. Kunal tried to say, let's focus on, the treatment part rather than talking about it. Although we normally deflect these kind of questions. How many of you think that's the way to do it, or should we be helping the patient know how long the patient is going to live? If you have an answer.
I would like to, like certain questions, I think I wouldn't want to ask in front of the patient, even as a family member.
No, Savita ji, hold on. It's not about this case. Generally, I'm asking, if the patient asks this question, all others can also answer. It's not just for Savita ji, all others can also answer. If the patient asks this question, how long am I going to live? How many of you think that yes, we need to answer this question honestly? Raise your hand. Dr. Tanu, you did not raise your hand.
No. I think you should not take away the hope ever.
I think when you're talking for the first time, breaking news, that time you cannot talk of death. No.
Absolutely, I agree. Maybe you will have to stagger the news, but then ultimately, because if with this, there will be another question where family will say, Doctor, please don't tell the patient about the cancer. Just say that we are treating you for something serious, but it is not cancer. And I've seen families where the patient has died and patient hasn't been told that you have cancer. What do you have to say?
I think
Ma'am,
their
I want to
patient.
say something.
One
Yes,
by
yes,
one.
ma'am. Tell me, please go on and I'll speak after you.
Yeah,
I
sure.
think patient should be told, the family needs to be told, that patient needs to know. But either you can do it in your own time, or if you like, I would do it in my way. And if you like, we can take some time about it, like maybe a day or so, while you sort out things around him.
Yeah.
But patient needs to know.
So what I'm saying, because a lot of time when they say this, it's important to ask what is your concern. Why do you want to hide it? So usually they'll say like the patient will lose hope. Like you said, the patient will lose hope. Or somebody might say this patient will not be able to take it, and rather we are actually preponing the death by sharing this information. But let me tell you, one, we are underestimating the power of the patient ability to cope up with this. You may have seen a lot of patients when they get to know, even then they keep trying to, look after, because the desire to live is always much more than the fear of going. Second thing is, even if it's my last 6 months or 1 month, I may have number of things, parked on one side thinking I'll do it later. Maybe I want to speak to somebody, I want to clarify things, I want to ask for forgiveness. Could be anything, or I want to make a will, or if I want to announce something. When you don't tell the patient, you are taking away those, rights from the patient. Some last moments that the patient wants to enjoy or spend time with somebody. So I think we really need to consider that. So when the family says that don't share this with the patient, it's important to let them see that it's okay, we can do it the way you want. But please see, the patient may have something on his or her mind as the last minute, actions. Each one of us has. When I know it's just the last few months or few weeks or few days, I think it's important to let the person know so that they can fulfill their last desires. So again,
Also,
they are
saying, psychologically prepared.
Yeah, you can stagger it. I completely agree with, like Pritaji said, of course, not on the first go, you will say, okay, Pritaji, Seema, or whatever the name you gave, Rima, this is what is your prognosis and you are there only. But no, I wouldn't ask you to do that. But at the same time, I think let's first complete the assessment. Let's start with the treatment. Some patients respond very well to chemotherapy, or some patients respond very well to surgery. And we have cases where patients have lived for quite a time. So it will be too early for me to give you a time like this. Let's start with the treatment, then come back to it. But then, we will have to ultimately tell the truth at one point of time, so that the patient mentally gets ready, the family mentally gets ready for the situation.
It's very difficult.
Yeah, it's difficult. I completely agree.
It's very difficult. It's very difficult because here it is, you want to tell the truth, but then you don't want to lose hope, or it could be that you're giving a false hope. So there are a lot of things that are contradictory, and at the
We
same time,
cannot give false hope. Please remember, you are calling for problem if you're giving them false hope. Please remember now.
But then when
it's
that's
not
what
like
when we tell them that few people have had a better survival rate, or they have responded well to treatment, so it is like giving your hope. I don't know whether it is false or otherwise. And
again, that has
the
to
patient
be
will start thinking.
No, Savita ji, hold on. All what you say has to have evidence. You are not giving false hope. I think we have to be very clear about it. If it is stage 4 and we know the prognosis is poor, I have to tell them that whatever we may do, we cannot prolong the life. Only thing is we can make the quality of life better by providing palliative care. I am not saying that you give this hope that, okay, when we are in the beginning of the conversation, when we have just diagnosed and when we know there is still a scope for chemotherapy, surgery, or radiation, that is where you will be saying that we have cases who have done very well, but we need to see what happens in his or her case. Not when you already know the prognosis is poor, then you are calling for a problem if you are giving a statement like this. When patients ask about cost of treatment, again, we can't say either I don't know or it varies from place to place. We need to have some figures to tell them what they have to arrange for or what is the possible expenditure.
True.
Never a one straightforward figure. Range may be given. It depends. It is between 10 to 20 lakh if you will go to a private setup, because each radiation will cause you this much, or each chemotherapy will cause you. Give them an idea. I know we are hesitant to talk about cost, but we have to get used to the idea of preparing the patient's family or patient that this is the likelihood of the expenditure. So I'm putting up these questions because we normally do not answer these questions in straightforward manner. When I say straightforward manner, it doesn't mean being insensitive. It is being sensitive, but being honest. What therapy would work, whatever you know, again you say, let's talk to the experts and find out from them. So they'll be able to give you a better idea. So I know breaking bad news is one of the trickiest, communication. And that's why I started with this exercise and also a couple of questions. Let me quickly share the screen with you and show you the presentation. Yeah, Dr. Tanu, you have something to say?
Sometimes it happens when a baby dies, like a newborn or some newborn or few days old baby dies. Family usually says, don't tell the mother. Like you tell the father, of course, and like in India, you have mother-in-law, father-in-law, you tell them. They often say, don't tell the mother. So what do you think should be done? Like family father has been informed. So legally you are covered because you've given the information. But like they usually say, when we go home, we'll tell her. So what do you think should be done?
So before I answer your question, I want to ask you and Amreen, because both of you have handled similar cases. How do you handle? How do you respond to it?
I actually usually, if they say don't tell the mother just now, I don't tell the mother.
Okay.
So especially like if the baby's been in the nursery or something, I don't tell the mother. And if it is a stillborn or something, then of course the baby doesn't come to the mother. So sometimes we take a couple of days to tell her. But yes, it is decided by the family when the mother would be told.
Okay, fine. Amreen, how do you handle it?
Ma'am, I have also faced some kind of situations. The baby used to shifted to SNCU, and most of the time, the baby used to suffer from like the condition used to be so critical. So mother had to keep apart in the other room. So we did not used to disclose the mother regarding the condition. We used to talk to the family members first, and then we used to ask them what you have. Then कि मैम अभी हमने बताया नहीं है, अभी हमने ये बोला कि baby is in SNCU and the condition may get better. But when then we used to talk to the mother. We used to know what she is thinking of the baby. And if there was a good rapport between us and the mother, then we used to tell this thing to her, but with counseling. Because ultimately she will know about it.
Absolutely.
Ultimately.
Absolutely. So we have two more gynecologists here from Afghanistan. So if Dr. Sherbano or Dr. Shifaza, if you would share your experience, how do you manage this in your country? If there's either intrauterine death or the baby dies maybe after a day or two in the nursery, how do you handle this? How do you inform the mother? Do you inform the mother or not?
Yes, madam. At first, we are telling the mother the condition about the condition of the baby and why the condition of the baby is deteriorated, and if it is die. So we are telling her if this baby was alive, then but so many disabilities and abnormalities were there. So better that you do not suffer of having an abnormal baby. So we have many sentences to tell her and to convince her. For example, if a woman abort an embryo, I'm telling her that I myself, being a doctor, I abort three fetuses. So it occurs with everybody. Although I have money, I have hospital, I have investigations, I have medicine, I cannot rescue my baby. So how can I rescue your baby?
Okay. So that way you talk to the patient and you explain and then you counsel. So again, there is no one line answer to it that should you be telling the mother or not. It depends. If the mother seems to be already aware of the fact that there are some complications and the chances of survival are poor, then probably she's already prepared for it. So it'll be easy for you to kind of, but what I feel right from the beginning, if you keep the mother in loop, and let her know. For example, if the patient is going to the NICU, then it will help to let the mother know that the child is in NICU. That means the condition is not good. So when they know the child's condition is not good, then death probably appears inevitable to them, especially if over a period of if you have been updating. Another good idea is to let the mother see the baby in the NICU. Because by seeing, everybody has an idea what is the state of the condition. Even in ICU for other patients, for adults, normally we restrict family members visiting the patient. I would say always allow the family members to go and see the patient. You will always see they will actually be moving their hands, like it will be on the side of their body, and it will be moving like this, or their head will be nodding like this. And what does that indicate? That there's a realization that the patient's condition is not good. Patient is not going to make. So when they are able to see the baby, they are likely to understand the condition is really, really not good. About this idea of telling that your child had abnormalities or some congenital deformities, I'm not sure if you should really be saying this if that's not there. If it's there, then definitely this will help you to prepare the mother. But whatever the real situation is, if you are able to put it across and simultaneously counseling and being supportive and being available and showing them the brighter side. But there is no one line answer that yes, you should be telling. For example, if the mother is already weak and has mental health issues, it can precipitate other mental health concerns. But if you think the mother already has an idea, is well aware that it's a complicated pregnancy and there's a possibility of fetal death, then probably she's already prepared for it. More depends on the support that we are able to provide after we announce the death. How the patient is going to react, we don't know. But if we are ready to handle that through counseling, by being available, by being supportive, you can manage the patient, you can help the patient come out of that. I think we have to focus on that. So it's just not the event of announcing, it's preparation before that and post announcement care, which will help you manage the situation effectively. Dr. Arjun, you have something to say, please go ahead.
Yes, if the patient, while breaking the bad news, if the patient is relative is really upset and they become aggressive, they say we are planning to file a police complaint. How does the doctor respond to that?
Okay, So one is, if you have done your preparatory work well, that means you have developed rapport with the patient's family as well. You have identified primary caretakers. You have addressed their concerns. You have actually answered their questions. You have even updated them on regular basis. That will come handy here. Then the likelihood of blaming that you haven't done enough, or you neglected the patient, or you did not inform us on time, all those questions will, kind of automatically get answered. But at the same time, when they say that I'm going to file a complaint against you, and I mean, rather than overreacting to it, and because usually patient and the family may say this out of anger. Studies suggest only 17% of the patient's family would go to the court, or or file a complaint against you. Most of them will say, and they'll quieten up. It's more like babbling. It's more like, just ventilating their anger. That's one thing. But if you're able to handle it well, it can actually also prevent the violence against you. The problem is, at this moment, we become aggressive because we are on defense. We start answering and fighting and blaming them. आप टाइम पर नहीं लाए, मेरे पे क्यों डाल रहे हैं अभी, अब कि हमसे गलती हुई है, आपको पहले आना चाहिए था, पहले आप इधर उधर धक्के खाते रहे, अब आप मेरे पास आए. So what you're trying to do, you're trying to blame them for it. Instead of that, if I say, I can't stop you from filing a complaint against me. I mean, if you think that's the solution, go ahead with it. But I can only tell you whatever was required to be done, all has been done. You can go to court, you can go to law. Will we be able to bring the patient back? Tell me, please. And do you think I have failed anywhere in doing my duty? But I can make these statements only if I have done my job well. The problem with us is when we haven't done things well, we have not documented, we have not communicated, so we are at fault. We are bound to be on defense. And that is where we are always in trouble. And deep down in every case, when you go, I was also discussing about this doctor's case in Rajasthan that happened. So one of the gynecologists was sharing that if we knew it's such a complicated case, we should know when to say no. We cannot take such complicated cases in a small setup. It was the statement coming from one of the very senior gynecologists. I was talking to her about this case. She said she already had 3 cesareans. I mean, all my sympathies and respect for the doctor who has lost the life. I mean, that doesn't undermine the loss. But if you look at, then rationally you got to look at the root cause so that you can prevent such incidences from happening in future. So even we need to learn to say no when we know that in a smaller setup we will not be able to manage a serious case. We are going by wishful thinking that I will be able to manage. 99% times you are able to manage, but one case is enough to kill the life. So should I move to the presentation? If there are, but I'm glad that you're asking these questions. So that shows that we are considering, how to go about doing it in a real sense. Okay. So we have discussed about what challenges do you think you experienced when you were playing the role of a doctor. The clinician perspective, what do you think in generally, why do people hesitate breaking bad news, or why are they not able to do it effectively? What do you think are the background reasons?
I think, madam, we expect a very bad reaction from the
maybe because of lack of
patient.
Very true. I think
especially in Afghanistan, everybody has a gun and they shoot the doctor.
Absolutely. I think this is a major concern, that we fear assault on us, or we fear that we can be gunshot if we. But in any case, if there's a death or a complication, that's going to be known. You can't hide that. But that gun is going to be then.
And then your communication skills should be that much strong that you can counsel the patient in a proper way.
Actually, right from the beginning, if you are able to, explain them and answer their questions and prepare them for whatever you think is possible, it will help you to tone down their expectations and make them have realistic expectations from the outcome. Plus, by this conversation, you develop a dialogue and a rapport with your patient, which is very important. Studies suggest patients and family members are less likely to be aggressive when they are familiar with the doctor and when they have trust in their doctor. Dr. Sharvano or Dr. Shivazo, you can share from your experience, because I know gun is a major problem in your country. So if you have good rapport with the patient and their family, if you have treated them with respect, you have always handled them well, they feel good, comfortable with you. Even then, have you had any incident where they showed gun to you on poor outcome?
No, madam. If we are close to the patient and to the attendant, they will never fight us. 1 month ago, we had a death in our hospital. And we were very lucky that the mother of the woman was a midwife. And it was a really bad incident that our midwife, fortunately, was busy in the cesarean, and the mother took the injection that I am a midwife, I can give this to my daughter. So as she injected that cefazolin to the patient, the patient condition deteriorated, and she was telling that my condition is deteriorating. They went to the gynae ward. Fortunately, we had anesthesiologist, and on the spot he intubated her and gave her oxygen and a cardiac massage. Everything was done for her. And unfortunately, she was died. Although she was hypertensive, she had kidney problem, but she had very small kids. It was really a bad condition for all of my hospital's staff. So suddenly all the attendants, male and female attendants, came and told, who gave the medicine? Then the mother told, I gave. Nobody did it. I myself did it. So and she was telling that all the hospital staff did many things for us. They did a lot for us. But unfortunately, we lost the patient. And yesterday, I made some halwa and bread, and with the hand of my midwives, 5 midwives, and with the car with the driver, I sent to her house for giving for example, here we do like this, that we are going to the family who lost the patient or a family member. Yeah. So I sent some halwa and bread. I talked to her mother by phone. So it was a very bad experience, and it was the first death in my hospital, and I will never forget it.
So when you sent it, they accepted halwa and bread?
No, they didn't expect, but they were happy.
No, they accepted it. They were happy with you sending it.
Yeah.
So a small gesture like this, I mean, they will always remember in their life. Always they will remember that this is what was done by the gynecologist or the senior doctor of the hospital. It's not just the incident, what happens before the incident and what happens after the incident, that decides the real impact of what we are doing. I remember Dr. KPS Malik, who was head of the Department of Ophthalmology, Safdarjung Hospital. I met him at AIMS Rishikesh. I had gone there to do a program for the resident. He shared his experience that in lot of cases, the patients would lose their eye. He's an ophthalmologist. He said in lot of cases, the patient will lose their eye completely, no vision, zero vision. Even then they will come back and thank him that you did so much to help us. We couldn't get the eyesight back, but we cannot deny the fact that you made all efforts to help us regain the eyesight. So it is not just the outcome, it is how we handle that situation also has a great role to play. So I completely agree. Clinician perspective is where people are scared that they will be embarrassed, they will be held responsible for the outcome, they can be blamed, they can be even beaten, they can be, humiliated. Even among the peer, they will have, a poor image where people will consider them careless or not responsible. But the reality is, bad news is something that you will have to share. You will have to share, because if it's your case, you are the one who will have to, bell the cat. When I talk about the patient's perspective, a study done in UK. Yeah. So that says that patients felt that 79% of the patient and 68% of the family said bad news encounter was suboptimal because physician was too blunt. So when we don't know the right way of putting across the same thing, that means we really need to know what is the right way of communicating whatever. Or the place or the time was inappropriate. A lot of time we do it in an open area. We do it in emergency. We do it bedside. We do it at the outside OT, outside labor room, outside ICU. Or the timing also could be wrong. And then patients also got the sense that there was no hope. They wanted physician to balance sensitivity and honesty. So as very, very rightly said by many of you, that we need to actually be careful. We don't have to be blunt, but at the same time, we have to tell them what we need to tell them. Then in another study, to find out what was the gap in what patients want and what they receive. Most patients are highly satisfied, yet 57% of them wanted to discuss life expectancy, and only 27% actually did it. Even if we saw our case, Dr. Kunal, patient wanted to, but we realized that we were uncomfortable talking about it. Then 63% of them wanted to discuss the effect of cancer on their aspects of life, but only 35% actually did it, because we are not comfortable talking about how that's going to impact a patient's life. Now, if I may ask you, what do we mean by bad news? What is bad news?
A diagnosis can be a bad news also.
Something like
A terminal disease, diagnosis of a terminal disease, or like something which is probably a lifelong situation if it is not terminal.
Absolutely. We normally think it's the death or any serious condition which is a bad news. I have seen mothers fainting when they get to know that their child is either amblyopic or high myopic or hyper, or high myopic or hypermetropic. And if they have to wear big, thick glasses for mothers and for parents, it's very shocking. And I've seen them, disbelieving, and they saying, no, we want to go and see another doctor and confirm. So it's not just death or complication or serious diagnosis. Simple diagnosis like this can be a bad news. I remember a medical student was brought to me by his parents who thought that probably this son had, has got stressed out because he was preparing for the entrance now into medicine, and medicine itself is very stressful. When I went into the details, I got to realize that actually the boy had OCD. And when I mentioned this to the family, they were really, really very shocked that they were in disbelief. So bad news is not just about, poor prognosis or serious diagnosis. Anything can be a bad news for the for the patient and the family. So if it has an impact on the patient's life and future and indirect bearing on the family and society, it's a bad news for the family. So what challenges do you think younger generation doctor experiences and why? You may have seen mostly senior doctors don't get to face, not like zero, but much lesser when it comes to in comparison to the younger doctor. So what challenges do you think younger generation doctors experience when they break bad news?
I
I
think
think the first
today's
thing,
Yeah, one by one. Please go ahead.
can I?
Yeah, please. Yeah.
Yeah.
please.
Yeah. So I think one of the major challenges which younger doctors face is inexperience, and inexperience with reference to seeing life in general.
Yes.
I'm not talking about the studies and what experience they have gained in the profession.
Yeah.
Because if you go back to your we started today's session with you talking about the CMO of AIMS. I think that's what incident you have narrated. It speaks of a highly emotionally intelligent person.
Yeah.
You know, that ability to connect, ability to understand other person's emotions, feelings. This is
Absolutely.
what is lacking.
Right.
So that is, and probably it is because that aspect has not been emphasized, or
Absolutely.
probably they have not been made aware of in the first place.
Absolutely.
So it is, and when we talk of EI, it is not just about understanding others' emotions. It is primarily understanding our own emotions and how we are able to handle it.
Absolutely. I agree
So
with
I
you.
think this is one. I think that is one
That means
thing.
somewhere there is lack of training and also lack of experience in handling emotion. And especially when it's a serious condition, then sometimes we do not have that kind of temperament also to handle it calmly, because during intense emotions everybody is likely to lose their control and become aggressive and get aggravated. So if you can see this picture on your screen, so they're carrying a dead body of a deceased, and they're carrying a banner over and above it saying that this patient died because of negligence of Dr. So and so, and that doctor should be punished very severely. I don't know if really any error actually happened in patient care. I'm sure there must have been communication failure where we failed to inform the family on time and prepare them for the eventuality. So you really need to do the homework in a manner so that it doesn't come like a shock to the family. So breaking of bad news is one of the trickiest and most difficult communication. Most of the aggressive reactions occur after the breaking of bad news. It requires advanced level of communication skills, especially great experience in handling emotions. And I think that is where we are facing problem. So one needs to be really good at words. The language part is very important. Body language, tone of voice, all that is very important. And then how do you handle your emotions and also emotions of others? So a lot of emotional intelligence plays a big role in handling intense situations like this. So word of advice, for everyone is it's always useful to have good rapport with every patient, because you never know which patient might turn into an emergency and have an unanticipated outcome. If you can make sure that you patient knows you, the family knows you, then it becomes easy for them to have this faith that you haven't done anything deliberately. So creating familiarity helps, because that studies have shown that patients and their family members are less likely to be aggressive. So the usual example I give you for this is, in case your car hits somebody's car or scooter and you are very angry because that person is at fault, and you literally come out of anger and want to fight with that person, but the other person who comes out of the other car is somebody who is familiar to you or known to you, could be your neighbor or maybe some friend, will you still go and shout at that person and hit that person? Chances are less, because you immediately oh, it's you, and then you are likely to forget that. So that's why creating familiarity by keeping the patient and the family in the loop helps in building rapport, and also having a dialogue with the family. Address their queries as and when they come up with. Do not shun their doubts or questions or concerns. Regularly update them, especially when you know the condition is critical, prognosis is poor. If you keep informing them about whatever the changes are happening in the patient's condition, they're better prepared for the eventuality. And then it's always a good idea to involve them in decision making. For example, if you're recommending surgery, radiotherapy, or for example, surgery or admission to ICU, rather than straight away saying that we need to shift the patient to the ICU, take little time and explain them that this is the condition. To handle this condition, we need to put the patient in the ICU. Tell me, are you okay with it? We have to learn this one sentence to use with the patient and their family. Are you okay with this? What do you say? Do you think it's fine? So in a way, you are empowering them with we are giving them a feeling that they have the free will to say yes and no, rather than we dictating. Because there was a time when we used paternalistic style of practice where we would decide on the patient's behalf. Time has gone. They want to at least feel that they have the right to say no if they don't want to do it. And we are not going to challenge them for saying no. So transparency and honesty would play a very big role in this situation. For example, especially when they ask about the outcome or they ask about the cost, duration of stay, the best option available for the treatment, they would get to know ultimately. If you don't tell them truly, they will ultimately get to know, but then you will lose your ground. You will lose your face in front of them. Let's remember one thing: when the patient is critical or has a serious diagnosis, the family is looming under the greatest fear of life. And what is that fear? Fear of? Unmute?
Death. Fear of losing. Yeah.
Fear of losing.
So anybody will go out of senses when they are, under this fear. Their normal cognitive functioning gets affected. Studies have shown that we look after the patient very well, but when it comes to families, concerns, we kind of do not take it seriously. Whereas it's the family who is actually handling the patient, finances, care, and everything. So they are under more strain and stress than the patient. And it's important to address their concern. By the way, we all know the breaking of bad news has to be done by the doctor. But what is the role of the nurses and the other paramedical staff?
I have observed that, the nurses and paramedical staff are not very involved. Like, it is more like they function mechanically. The doctor has asked them to do certain things. They come and they go, they come and go, and they go about doing whatever needs to be done. It is like, it's, I think probably they are scared to say anything, or for the fear of probably they may be saying the wrong things, or probably they may be putting themselves at risk.
So it's not just about talking about the condition. It's also about, being helpful and kind to the family and understanding.
Correct.
If somebody else would like to add their point, if somebody else would like to, share their thoughts about what do you think is the role of nurses and paramedical staff?
I think they are the silent social support system in handling the crisis, because the doctor is being clinical and explaining everything, but just finishing the paperwork, or even just being around, or having water around for them, or the nursing just being there. Sometimes just there being physically around the family is a big psychological.
So I think there's small request that they ask for.
Yeah.
If even that can be looked after, that can be a great thing. Even if you're not able to
responsive.
Being responsive, I think that's very important. If the family requests for something, Amreen, you wanted to say something.
Yes.
Ma'am, what I have seen that the nurses and the paramedical staff, they are just concerned about the treatment only, which is written on the sheet. They feel that it's their duty only to give the treatment which is ordered to them. They don't concern about the other things. And if the family or the patient asks them for anything, they don't even respond.
Amreen, is it only with nurses and paramedical, or it is even among the residents also?
It is among the residents also, ma'am. It is there.
Unfortunately, I think all of us, if it is a consultant case, we assume it's consultant responsibility to answer the patient's concerns or the family's concerns, and we are just there to look after the treatment part. Whatever medical or nursing intervention has to be done, we need to do that, and rest of the responsibility lies with the doctor or the consultant who is treating. Dr. Tanu, you want to say something?
I think it depends. It is up to the top person in that unit or whatever to create the right kind of atmosphere. That culture of caring has to be created by the top person, and that has to trickle down.
Absolutely.
Like I remember my father had a bypass in National Heart Institute, and the nurse, she like closed the door very loudly. And Dr. Yadav, he really took her to task about this. You cannot do this. So it is how you create that environment that has to come from the top person.
Absolutely.
So I think that's important.
Dr. Anuradha, you want to say something?
Ma'am, since you asked about the role of nurses, the number of times they come in contact with the patient is much more than the doctor. The doctor would come morning and evening for a round, or just ask the well-being from the nurse sometimes. Absolutely. If he's in OT, but then the nurse will keep coming. So if she has the empathy and the compassion of the patient is suffering from a condition and I'm in touch directly with him for the continuous day, so that will really help the patient.
Absolutely. Yeah. So that's what I was trying to say, that though you cannot break the bad news, you cannot talk about the prognosis. That's the responsibility of the consultant who's attending the patient. But in general, I think the resident nurses and support staff working in critical care area, they need to be more sensitive to the family's needs. Especially a lot of time I tell them that in case if the patient's prognosis is poor and that patient will not make it, the family would want to come and see the patient. At times we become very rigid on it and we say nothing doing. I mean, you can only visit during visiting hours. But try to understand, probably these are the last few hours when the family can see their patient alive. So you being considerate and understanding, they will always be thankful to you and will always be, appreciative of your help and consideration, because you accommodate it. So these are small things. Sometimes they want to do some ritual, allowing them to do that, or something that is possible. Of course, in a lot of corporate hospitals now, they are proactively providing these services where you can call a spiritual healer, or you can do the puja and prayer in case if the patient's likelihood of survival are very low. But I think in general our attitude towards the family has to be more full of empathy and compassion and care, because they are going through a tough phase of their life. And if we be rude and mechanical in those hours, I think it's very hurtful. And it's not just the nurses and support staff. I've seen consultants, I've seen residents, everybody like being rude and to the point and very mechanical when it comes to actually handling the patients and families concerned. Of course, the breaking of bad news should always be done by a senior most person, because the person who has seen the patient, who's been working on the patient, is the one who should be doing it, because they would be well versed with the patient's condition or whatever has been done, or what is the likely hood of what will be the prognosis. So let me quickly share with you the protocol of breaking bad news. Of course, there are multiple protocols available, but I find this very useful, and I normally share this one. So this is actually 4 P's, that is like the protocol of 4 P's. Then there is one spikes also, another protocol of breaking bad news. So in this 4 P's, first P is preparation. That is, before you go and announce, there is some preparation to be done by you before you go and talk to the patient's family. Then second P is about placement, place where you're going to do it, and then preparation of the patient. So these 3 things will come in the preparation part. Second P is about performance. How do you go about doing it? Third P is about palliating, and fourth is planning. So when we talk about preparation part, I think it's very important to know and confirm the facts before you go and announce anything. We have seen cases where one patient's reports are attached to another patient's case file. Nobody actually got to realize this. And the doctor has gone and announced to the patient, and then later on you get to see, oh, this report did not belong to this patient. But the damage has already been done. So it's very important to be 100% sure of what you're going to share with the family. Before you talk about it, it's good to have a small talk before the big talk. So make a connection with the patient and the family. Don't do it mechanically. I mean, by just saying, okay, you are Rajesh, okay, son of patient so and so. Oh, I have met you a couple of times. Even that's a good way of making connection and letting them know that you know them and they are familiar with you. I'm really sorry. I have some throat issue today. Okay. So when you're able to make that connection, they feel that it's not being done in a very monotonous, monologue kind of a thing. Then when you will talk about, say, cancer or anything, maybe infertility or fetal death, or this is not the end, this is the beginning. So they will have a lot of questions. Why this happened? Why this happened to me? What can we do to change the outcome? Can we go to another hospital? Is there any treatment available? Can we try allopathy? Can we try homeopathy? Why did you not tell us earlier? So they'll have a lot of questions to ask. So please be mentally ready to spend some time. Otherwise, they will feel that we have not been given a fair explanation of my condition. In between, attending phone calls or going out and coming back or attending to somebody is not a good idea. So always please manage interruptions that can give a feeling to the patient or the family that we are not getting 100% of the attention. I've repeated, please do not delegate, because normally I've also seen a lot of time senior people would put on the junior's head and they'll say, go and tell the patient, go and inform them. It has to be done by the person who is actually looking after the patient. Yes, Dr. Tanu, please go ahead.
In fact, one of the reasons there is so much of violence against doctors is that it's usually the residents or actually the junior most person in the hierarchy which is giving the information that, okay, your patient is no more. Yeah. So obviously that is why they become the brunt of all the anger.
Yeah, of course. And especially when they are doing it in little mechanical manner, not realizing the emotional value of the situation and not responding to it, effectively, that really, really aggravates the situation. And that's why I'm repeatedly saying that it should not be delegated. It should be done by the senior most person, so that the person can address their emotional concerns and their questions. Yes, Dr. Arjun, you want to say something, please go ahead.
Ma'am, you said, yes, building a rapport with the patient is very important.
Yeah.
But sometimes due to scarcity of time, when the patient comes to the emergency or casualty, and there some incident happens, patient is dead, that time you would not have built a rapport with the patient relatives. So what I feel is, if they can take the family physician or some doctor in the family to confidence and explain them the situation, then the family physician can update the family members, so that I think this way violence also can be prevented.
Absolutely. So true. That's what I think we discussed in the beginning when Dr. Tanu was mentioning about where we don't have a chance to, we don't get a time to build rapport with the family. So I gave you that example of that casualty medical officer who said that one team will be working on the patient and I would always go and talk to the family. That means this thing is going simultaneously. You're not linearly waiting that after we have some prognosis or outcome to discuss. 1 second. Yeah. So it's always important to value this, that you need to, talk to the family simultaneously. Then in government setup, when I would ask doctors that, do you update the family on regular basis? So they will say, we don't have time. We are so hard pressed, and you expect us to go and talk to the family. So I would say all 100% patients coming to the emergency care or in ICU are not going to die. But if you can identify patients who are likely to have poor prognosis and can die, at least with their family member, you can start having a dialogue. Let them know that the condition is serious. I talked to another doctor, she was also a casualty medical officer, and she said, what I do is, the moment patient is brought in the emergency, usually there are a lot of attendants with the patient, maybe 5, 6 or 10 of them. I would always tell them, please wait outside. Let us first work on the patient. The moment we are able to stabilize the patient, I will come back to you and talk to you. She says, every time we have settled the patient, I will go and tell, okay, tell me who all are with the patient here and who are the closest family member. So, okay, 3 of you, please come with me. Let me explain you the patient's condition. She says, then I take good 10-15 minutes to explain them how the patient was brought in, what all has been done, what is the likely outcome. And then whatever questions they have, I address them. So, and then I also tell them, now please, whatever I've shared with you, go and share with your family member. Next update will be after 2 hours or 3 hours, or maybe whenever I think I need to come and tell you something, if there is any change in the situation. So we have to kind of tell them that we are going to communicate with you and don't feel at loss of information. And if you can bridge that gap, even that is good enough in such situation. And plus, I think overall our gestures and our way of handling situation has a role to play. I remember in one of the government hospitals, a young boy, I think 15, 16 years old boy, he was playing with kite, it was probably that August month when we have a lot of kite flying thing. So that poor boy, he got in touch with that computer cooler, and unfortunately he got electrocuted. He was brought to the hospital by his parents. The residents on duty tried to, did the protocol of resuscitating and doing CPR. And then they announced that the patient is no more, the child brought dead. Family accepted. They went out. Somebody said, please ask them to do it once again. A lot of time the patient comes back after. Now imagine that denial, that wishful thinking that maybe the patient will come back. They come and request the residents, and how the residents handled it. डॉक्टर मैं हूं, आप कर लो. अगर आपको लगता है कि बचा सकते हो, आप कर लो. And you can well imagine what must have happened after that. So as I said, how you handle before that, how you handle during that, how you handle after that, everything has a role to play. So even in emergency care, if you have an eye on engaging the family, talking to them, that would play its role and pay you off. So when you are breaking the bad news, it's always a good idea to do it at a separate place. Of course, in most of the corporate hospitals, we have counseling rooms where we call the family and we sit and talk to them. In government setup, I think we don't have separate place for counseling. There we have a challenge. But if you understand the value of doing it in a separate place, sitting down, that will really help you understand why it is important to sit down and talk. One is, if you're doing it in corridor, the risk is there are others who are overhearing your conversation. There'll be bystanders. They can interfere. They can even instigate. They can also come and fuel the situation. That's one risk. Second thing is, when we are doing it in a public place, even we are conscious. When the patient's family says something that could be upsetting us, we also react to it. Whereas the same thing, when it is said in a separate room, you are less likely to react to that statement, because it's okay. They are saying it's fine because they are upset and they are very they're in grief. But when they say the same thing in public place, even our behavior changes and we become conscious of the fact that, okay, the patient is insulting me in front of others. Also, we have to remember, when you do it sitting, the family and the patient would feel respected. They feel that, okay, we have been treated fairly, equally. And also, when you sit and talk, the energy to fight and become aggressive goes down. You may have seen when people are angry, they will stand up because they need energy to fight. So if you make them sit and talk, usually their energy to fight goes down. When you're talking to them, ensure their privacy, especially if you're talking about a sensitive issue. It's important to make sure that their information is not, heard by others who are not concerned about it. It's a good idea to involve significant people like their relatives. For example, if there's a senior member of the family who you think will understand better, take them in, or a social worker or a psychologist or a senior nurse. They will all help you in handling the emotions. Having facial tissues, a glass of water, or maybe a bottle of water if you don't want to use the glass because you risk that they can break and harm you. Maybe the disposable water bottle can be kept handy to offer them a glass of water. So before you say them anything, it's very important to assess what does the patient know, because that will tell you, are they really prepared for it? For example, when you ask them, what do you know about your condition? What do you think it is? Or what has your referring doctor told you? They'll come up with you, डॉक्टर साहब वो तो बता रहे हैं कैंसर है, डॉक्टर साहब ये गिल्टी तो मुझे बहुत दिनों से है, कभी कभी पेन होता था, कभी कभी मुझे लगता था कि कैंसर है. So what it is, they are kind of already, I mean, they have an idea about it. Or for example, when you will talk to them about this, you will also get to see that they have just no idea about their illness. You may also see illness denial. डॉक्टर साहब मेरी फैमिली में तो कभी किसी को हुआ ही नहीं, कैंसर का तो मतलब ही नहीं है, मैं जो HIV हो ही नहीं सकता, मैं आज तक कभी मेरे अपनी वाइफ के अलावा मेरे कभी किसी के साथ रिलेशनशिप नहीं थी. They may not have any idea. It could be also from blood transfusion or the other possible reason. Or there can be wishful thinking. कुछ नहीं होगा, मुझे पता है ये सब ठीक हो जाएगा. Or there can be unrealistic expectation of the treatment. So if you can identify them, please address them appropriately. Don't let unrealistic expectation go unaddressed. Otherwise, later on you will have challenge. In case if there is any misinformation, please correct. कभी lot of times you'll say, डॉक्टर साहब ये तो बिल्कुल ठीक ठाक आए थे, बातें कर रहे थे, खुद चल कर आए हैं. So that means we have done something that the patient has deteriorated. So we need to correct this by providing right information. ऐसा नहीं है, बेशक चल कर आए थे, पर आपने देखा हो होश में नहीं थे, चल नहीं पा रहे थे, गिर रहे थे, अपना नाम भी नहीं बता पाए. That shows that sensorium was affected. So correct misinformation by providing them the right information. And in case if you see there's a lot of illness denial, anger, aggression, tailor the bad news. Don't give it immediately. Maybe we need to stagger it. That's another point that you need to keep in mind, that is check patient's information need. How much does the patient want to know? A lot of time when you will ask them, how much do you really want to know about your condition? डॉक्टर साहब मुझे कुछ नहीं सुनना, मुझे इलाज कर दीजिए बस, मुझे ज़्यादा कुछ नहीं सुनना. A lot of patients would want to know everything about it. So it's important to know how ready they are and how much do they want to know. Although we don't care for this, we normally say whatever we want to say, but that will really help you in making sure that you don't tell more than what the patient wants to know. Sometimes giving more information can do more harm. So it's always a good idea to share what the patient wants to know. So according to this study in UK, 231 patients visiting a UK cancer center were asked. 98% of them wanted to know if the illness was cancer, because they wanted to be clear about it. And 87% of the patient preferred as much information as possible. I think every patient would want to know, especially if it's a matter of life and death. They want to know how long I'm going to survive, what is the prognosis, what will be the quality of life. Now coming to the second P, that is performance. Whenever we do it, we have to be sensitive but straightforward. Please do not try to minimize the severity, because any intention to soften the blow can lead to weakness and confusion. But it has to be done in an empathetic manner. While delivering the news, use simple language, avoid technical jargons, avoid single steady monologue. It should always be dialogue. Dialogue will give you an idea what is patient thinking, how is patient going to react, how is patient taking, is patient understanding, is the patient, because a lot of time you will tell everything and at the end they'll say, Doctor, bach to jayega na. That means they have not been able to understand the seriousness of the situation. Pause frequently. When you pause frequently, one, they get time to digest what you have said, assimilate. Second, in case if they want to react or say something, you will be able to give them an opportunity to ask something in between. Check for understanding. As I said, it's very important to ask, are you understanding? Are you realizing how serious is the situation? Because a lot of time they will be nodding, but they will not understand. That's again a very risky thing. Use silence and appropriate body language as tool to facilitate discussion. So you don't have to always talk to facilitate. Sometimes when you become silent, they will ask you a question. Your body language plays a role. When you lean forward, when you nod, when you make eye contact, when that seriousness on your face shows that you are also concerned about them. They feel like talking about their feelings and sharing their thoughts with you. We have talked about it earlier also. 7% of the communication is through words. Rest all is your tone of voice and body language. So make sure that your tone of voice and your body language is congruent with the situation and your, language and the vocabulary words that you're using. So when we talk about the body language part, I think making eye contact and greeting softly plays a very big role, because when you make eye contact, that shows that you are connecting with them, and also you're not guilty of anything. When we avoid eye contact, they may read it as that we are sorry or ashamed of what has happened, or maybe we are responsible for what has happened. Maintaining open posture plays a big role. We have talked about it earlier also. Leaning forward, listening attentively, nodding, tone of voice, as I said, allowing them to speak when you pause and you use silence, and accepting emotional reactions without being too reactive. You don't have to, nod like this. No, 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 no. What you're saying is wrong. How can you say this? So that means I'm not allowing them to express what they're thinking or feeling. Comforting the patient or family, maybe touching on the hand or on the forehead or shoulder. Again, but be careful. We can only use such gestures if we have good rapport with the family. So these are a couple of ways that we can use to, start the conversation, where you say, I feel bad to tell you this, or unfortunately, the test reports are really very, shocking. But the truth is that, yes, I'm really sorry to tell you that this is what is the diagnosis or whatever. So this is how you can actually start your dialogue, that again shows your human side, and they get a feeling that, okay, you are also affected by it and you are kind of concerned about them. So, bad news results in cognitive, behavioral, or emotional deficit in the person. Selective hearing, selective listening, selective forgetting. These are all very common processes you will see. They may not remember, they may not realize. So because it's too big a shock for them to actually process it in a right manner. Of course, clinicians cannot change the news, but clinicians can make the news worse, or they can help give realistic hopes. What is the usual response? They'll either cry, they'll become silent, or they may say, are you sure? Could be my reports are wrong. Would you like, can we get it done from another place? Can we repeat the test? Or some of them may say, please don't tell my husband, don't tell my wife, don't tell my parents, don't tell my children. So this is a usual way they will react to it. The psychological response to such news or the grief is dabda. Dabda is denial. They may completely deny, they may become shocked, they may become angry, unhappy, aggressive, revengeful, and they may blame us for the outcome. Then they'll start bargaining. Can we do something? Can we try this treatment? Can we take him somewhere? Can we have second opinion? That's actually, they're trying to see, how can I do my best to save the patient? Once the reality sets in, they start quieting. They become quiet and depressed, and then finally they accept it. How do you handle it? Okay, so in a study of 100 patients diagnosed with cancer, it was found that 54% of them actually reported shock, that they were really shocked to hear this. 46% reported being frightened. 40% accepted it. 24% reported sadness. Only 15%, they said, I don't care. I'm fine with it. I'll manage it. I remember I came across one patient. She was visiting my husband's clinic, and I was by chance there, and I saw her completely bald. And the way she was laughing and talking, I couldn't even think that this could be anything very serious. But she suddenly said that I am in stage 4 cancer. And but I don't care. I want to give task to my death or cancer. In Hindi, if I say, what she said was, मैं भी कैंसर को बताना चाहती हूँ कि उसका किससे पाला पड़ा है. That was the state of this thing she was talking about. But I haven't seen very many patients who can take life like this. But yes, patients who are diagnosed with serious diagnosis, they do experience shock and disbelief, and they would ask you questions like, why me, and I haven't done anything, or you haven't done on time. So how do you handle this? Denial should be handled with information. Provide them information, whatever reports you have, whatever investigations you have done, whatever the signs and symptoms are. Give them that information to understand what it is. When they're angry, please do not retaliate. Please do not reply in anger. Stay calm, listen to them, and be supportive. If they are bargaining, help them see the reality by showing them results or the other facts that can help them see the reality. Be empathic, at the same time assert, because a lot of time they will say kitna bhi paisa lag jaye, kitna bhi wo lag jaye, aap bacha dijiye. So you will have to assert there, where you will have to explain them that money doesn't decide the longevity of life. If you see them depressed, giving them direction, what needs to be done, because at this stage they are confused and they are just clueless what next. So it's important to give them direction and let them know what needs to be done now. For example, if they need to decide about going to a specialist center or another, cancer center or other places, so you need to tell them what needs to be done. And once you see them accepting, I think it's time to encourage them and support them in whatever we can do. So empathy plays a very big role. We have talked about it at length in our previous this thing. I mean, just this role play should tell you empathy with the doctor who does it, empathy with the patient who listens, and the family who has to bear the brunt of the situation. I think all of them are, alone in their own positions, and they need that care and compassion. And we talk a lot about second victim now, because we know even the clinicians are affected by what they have to face. This we have talked, so I'll just speak quickly. So these are again some of the statements that will help you to express your empathy. For example, I can see how upsetting this is. Anybody in your place would be upset. Even I was hoping for a better result. Unfortunately, really sorry to have to. So these are the ways that will kind of create a dialogue and a rapport with the patient and their family. Of course, clinicians, when they have to break bad news, they are uncomfortable about the patient's expectations. If a patient came with a very high hope that I'm going to be fine and I'm in the safe hands and this is the best center and you are the best surgeon, definitely you are uncomfortable about the expectation that the patient or the family had from you. You also fear that you're going to destroy the patient's soul, that you tell them this is what it is. We also feel inadequate in the face of uncontrollable disease. I think we have recently experienced during COVID how helpless we felt in that situation. And we saw a lot of patients going, out of our hands within a few days. Then sometimes we are not even prepared to manage the patient's anticipated emotional reaction. I've written anticipated because we got to know that these emotional reactions are part and parcel of breaking bad news. And we need to know how to handle it. And sometimes we are embarrassed at having painted too optimistic a picture for a patient. For example, when we say, don't worry, this is stage 1, don't worry. And then suddenly we realize when we get PET-CT done in a period of 2 months, it's already metastasized in various parts, and then you are shocked to see the changes. Or I remember a case where the patient had to undergo cholecystectomy, and she was a young lady and she had a child at home. She told her doctor, I want to see my child before I go for the surgery. And the surgeon said it's just 10 minutes job. By the time your child will come, you will be out of the OT and then you can meet your child and manage. She agreed and she went for the surgery. Unfortunately, there was a complication on the table. She went into coma and then died later on. So no procedure is risk-free. I've seen patients collapsing even with test dose. We cannot give them, consider that, oh, nothing is wrong. So how do you really prevent these situations where you don't have to face this? Please give realistic expectations. Never give false hope, never give false information. Please give realistic expectations. Accept professional limitations. We are human beings and not gods. Whatever we have at our hands, we can only manage within our limits. Learn to control your emotional reactions, because usually things go out of hand when we react to it. Family is bound to react. Can we control our reactions? Keep the family updated, especially when you know there's a likelihood of poor prognosis. They are like less likely to be aggressive or lose their control. And very important thing is document all communication. We do all things that are possible, but when it comes to documenting, sometimes we are not very particular about it, but then these come handy when we are in the court of law. Once you break the bad news, patients fear that they're going to be left out, they're going to be abandoned. Very important here is to sit with them and establish a plan. In case if you need to refer, just don't say that, okay, I'm referring you to Rajiv Gandhi Cancer Hospital or this is Cancer Hospital. Establish a plan. Treat their current symptoms. If it is pain, fever, bleeding, anything, whatever you can do that so that they don't feel that they're just chucked out because you are no more their case or they are no more your case. Discuss the next treatment plan. They may want to understand what is chemotherapy, how many doses are given. I mean, it's very important to know, like both of you said that we should know what is the treatment protocol. If we knew, we can answer their questions effectively. So it's always good idea to discuss with somebody, maybe to whom you want to refer. If you discuss and you say, okay, can you tell me about what is going to be done, and then whatever the patient asks, you can answer those questions. That shows that you know the case, you know the next steps. And then they may want to come back to you for follow-up. Maybe in the first go, they haven't even understood and they're very overwhelmed and they want to come back and then clarify you. Or maybe later on, even if you have referred them, they want to come back to you because you have built rapport and you have been in touch with them for a longer while. Definitely at that time, giving them a chance to come back to you and discuss their case will help them. And reassure them that they are not going to be abandoned. It's just because they need to go to a better place for their treatment, you are being referred. Arrange for appropriate referrals. If possible, give contact details of the person to whom you are referring. That will really give them satisfaction that we are properly being handed over. Of course, make sure that you give a complete summary with all possible details to the patient and to the referring doctor so that they get a overview of what has been done and how you have reached to this country. Involving potential source of emotions and practical support like family, friends, social workers, spiritual counselor, peer support group therapists is very, very helpful, especially when we feel we are not able to handle emotions effectively. It's always a good idea to involve them in. That will bridge the gap and that will provide them support and care. Disease and death, I think we'd only get to realize how scary they are when we personally experience something like this. So those of you who have seen it, I'm sure you would understand how bad news actually affect each one of us and how that completely derails the family, situation before it comes back to normal. So with this, we come to the end of this particular topic. I know we have gone much beyond the time and we have 2 presentations to be done. But I could not cut down on the content or on the practice session. So please bear with me and let's have the 2 presentations by the 2 presenters. Any questions before we move on to the presentation? I'm well aware that it's already 10 o'clock. Any questions?
No questions. Today's session has been emotionally draining for me.
I can understand.
So, it's a lot of things have happened in the past few days, past few weeks. So everything is like a refresher course about that. Nothing more.
Sorry. I feel bad. Really sorry.
It's okay. It's okay.
But that tells us how the patient would feel, I think. The family.
No, I have learned one thing that it's a very challenging situation for a doctor. I have learned this. For me, it has always been from the patient side, whether it was for my father or mother. But today, it was an eye-opener, understanding what doctors go through.
Absolutely.
So it is very difficult.
It's not easy. It's not easy. Even if they have kept the family loop, even they've informed, losing a patient is actually a loss. It's not something that anybody would want. Anybody would. Thank you. Thank you. So can we have presentation? I think we have presentation by Dr. Tanu. And who is the second presenter?
Chandana?
Chandra was in the next.
No, ma'am, it's me.
Okay, it's you. So who all are left now?
Ma'am, I am left for the last session, and I think also Navnita.
And Dr. Arjun also.
Yes,
So please be ready for the next session. That means we will have because disclosure of medical error is equally important topic, equally interesting, and you'll get to really see, a broader perspective of the topic. So please be ready for at least spending half an hour more than the usual time. I'll try to keep it short, but at the same time, I feel that if the discussion is useful, meaningful, and it's going to help you, I don't want to curtail the discussion, but you can tell me if you want me to stick to the 1.5 hour time, I can cut down on the content. Or you can bear with me for the next session.
I think that will be our last session.
Yeah.
So we'll bear no issues from my side at least.
Wonderful.
I'm good.
Or what we
If
can
everyone, sorry,
yeah.
If everyone agrees, at least for one session, can we start at 7:30?
Exactly. I was about to say this,
Yeah,
that we can start at 7:30 if everybody is okay with that idea. Anybody who's not okay, please raise your hand. That means everybody's okay. Okay. Next session we'll have at 7:30 so that we can finish by 10 o'clock. Thank you. Thank you. So Dr. Tanu, if you could. So you want me to.
So you'll need to make me the co-host.
Sure. Give me a second. Done.
Okay. So just a second. Okay, so I have this tennis ball here, and I would like your suggestions on how we can utilize this tennis ball. So you can please write in the chat box. All suggestions are welcome. There are no weird ideas. There are no stupid ideas. So please feel free to write in the chat box. Since I'm not able to see the chat box, I think Dr. Indu, if you could just see what is being written in the chat box. So you have 2 minutes to put your ideas.
To play cricket.
Okay. What else? Anybody else? Please feel free to have any kind of ideas. Anything other than games is also fine. Dr. Chandana? Sorry, Chandana?
Yes, ma'am. What I am seeing here is like it doesn't look like yellow. It looks like green. That's the first thought came to my mind.
Okay.
And I think I can play tennis with the tennis ball, and of course cricket.
Okay.
And sometimes, I mean, we can simply play a simple game of catch and throw with this ball.
Okay.
So Dr. Anuradha has written, we can play with our pets using the ball. Good idea.
Okay. What else? Dr. Arjun?
So to play cricket is what I thought.
What else? So you can think of something other than games also?
You can use it to hit somebody.
That's a good idea. Dr. Savita?
Yeah, I would not, but I just.
I think everybody had this thought, but nobody wanted to say this
Yeah,
because
so I think I thought so much. I thought lots before saying this. Oh shit, I've been labeled as violent, but I'm not violent.
So what else?
I was thinking we can break somebody's glass with it, a window pane.
Right. Definitely we can do that.
Okay, Dr. Amreen has something new. We can make
Probably I can use, yeah, creativity is what I was thinking. Probably use it as a base to do some macrame or carve it and come up with some creative idea, like probably use it as a bowl or come up with something more creative.
Right. Good.
We can also use it to do some kind of exercise, like we
Chest
normally
buster,
use it,
chest buster.
for
Yes.
hands and also leg pain and for back pain. We normally use it.
Oh yes, good idea. Dr.
We can
Kunal?
put it in the washing machine while washing soft toys or cotton linen, so that they don't get tangled.
Oh, that's a great idea. Good.
Yeah.
Dr. Sherbanu?
Dr. Kunal, why do you use it in the machine? What is the idea?
The pillows or the soft toys, the cotton inside doesn't get tangled, so the ball helps them keep it
Untangled.
Yeah,
I didn't know this.
Dr. Sherbanu?
Everybody will go and try it, I'm sure, in the washing machine.
I was thinking we could cut it in 2 halves and use them as a small planter.
Yes, we can use them as planters also.
But nobody will like the idea of cutting such a good-looking ball into 2 pieces. Only because
well, then it will be useful.
Yeah.
So this is my presentation today, brainstorming as a way of facilitation. So brainstorming is as a technique was developed by a Medicine Avenue advertising executive, Alex Osborne, in 1948. It is a group technique of solving specific problems, amassing information, stimulating creative thinking, developing new ideas by unrestrained, uninhibited, and spontaneous participation from all members of the group, just as we have seen just now. In context of training, it is a pedagogical tool used by a trainer which encourages all or maximum students to present new ideas or views and enhance participation. So where all you can use it? You can use it where a lot of ideas are needed in a short time, where creative, original ideas are desired, like how to use a ball, where we do not have ready answers, unconventional problems, where participation of entire group is desired, where consensus is required, where everybody's views have to, everybody has to agree to each other's views, as a teaching approach to engage students in problem-based learning. Since we are presenting a problem, it encourages them to think and come out with creative solutions and encourages problem-based learning. Very interestingly, where you require a creation of inclusive classrooms I found that it is used especially in students with special learning needs also. So I'll just give you another video about a brainstorming session.
All right, team. Thanks for coming for a brainstorm today. We have a really interesting topic. The local zoo, the visitors are down 20%. So how might we boost the number of visitors to the zoo? This is a very topic. They want to stay open. They need recruiting, all this kind of stuff. So
Oh, sorry.
let's spend a few moments now first and get a few ideas. Remember, we're going for quantity. Let's see how many ideas we get, and also some really good ideas out there. Let's push ourselves. All right, so I'll start us off. I had a date night. All right, what else you got?
To build like warehouses and stuff. So it could be all these but they're sort of less. So
Let's get 5 or 10 more.
I figured loyalty cards, airlines, and
Celebrity thing. Like we pretend the animals are celebrities.
the teachers, the barn.
What we'll do next, some themes, and then prototype one or two, and then
So this was a brainstorming session where the problem was how to increase the attendance at a zoo. So how do you brainstorm? Have an appropriate, comfortable meeting place with adequate pens, visible board, post-its, and even you can have like digital screens or things like this where you can put the suggestions being given. Appoint one person to record all the ideas generated. Consider an icebreaker, like if the participants are not known to each other or if the atmosphere is not relaxed, an icebreaker can be used to make the whole situation very informal and relaxed. Present the problem clearly. Explain the do's and don'ts. We will come to the do's and don'ts in the next slides. Give adequate quiet time to generate ideas because they just cannot start coming out of the blue. So people have to have time to think about it. Fair opportunity to everyone to share ideas or even build upon the ideas shared by people previously and record them. Follow with a group discussion to collate the ideas, organize them, evaluate them, and then rank them according to how you feel, how the group feels that they can be used. Follow up and feedback to the group. So the next thing is, what are the do's? Brainstorming is an informal, unstructured activity, but yet certain rules have to be followed. Otherwise, it will lose focus and it will become a very free for all kind of activity. So the most important rule is there should be no criticism. It is very important to approach it with an open mind and a spirit of non-judgment, because if that doesn't happen, people clam up and then they don't speak out. And nobody should be allowed to criticize the idea or even appreciate the ideas right in the beginning, because that happens when you have a follow-up discussion. Unusual ideas are welcome. Encourage wild, weird, unusual ideas. No idea is stupid, no idea is silly, no idea is impractical. So every idea is welcome. Focus on quantity, because greater the number of ideas generated, the greater are the chances of having a useful, radical, and effective solution. And encourage piggybacking, because like somebody has given one idea, then you can combine or you can improve, others can give their input on that idea, and the idea can be built upon. Other do's are guide the session. Like I said, it's very important to guide the session, otherwise it can become free for all. Create a safe, inclusive, supportive, and fun space. Ensure everybody participates. Clearly define the problem to be discussed and set a clear intention. Allow preparation time, some time of silence for everyone to think about the problem. Record all ideas, be visual, because if they can't see the ideas, one is likely to lose track of them. Put a time limit of the session, otherwise it can go on indefinitely. Have people from diverse backgrounds. Stay focused. Refocus the group if people get sidetracked. One conversation at a time. If sometimes what happened, the conversation gets stuck. People cannot come out with ideas. So there are certain creativity techniques like round robin, in which one goes around and asking everybody for an idea. This encourages people to speak. Then there is something called double reversal, in which instead of stating the problem, like suppose if I want to reduce the waiting time in the OPD, I ask the question, how do you increase the waiting time in the OPD? So when people come up with those solutions, they can be reversed back to have solution to the original problem. Then there are techniques like starbursting, where you go into the why, how, when, where, who of the problem, so that clarifies the solution and it builds upon that. Again, follow up and feedback is important. And it's important to thank the participants for the effort that they have taken, which I did not do. Thank you for the effort you people took. And what are the don'ts which should not be done? Don't allow it to become a chat session. It is not a chat session. It has a certain aim which should be taken care of. Don't make the group too big. 8 to 12 people work well. Don't criticize, judge, or reject any idea. Don't be afraid to share unrealistic or unconventional ideas. Avoid anchoring effect. Anchoring effect is what happens when first 2-3 ideas come up, then everybody gets focused on that and the new ideas stop coming. So that should not be allowed to happen. Sometimes people just get together in groups and start talking among themselves. That shouldn't be allowed to happen. And sometimes some participants dominate. Again, that should not be allowed to happen. Don't allow it to become a competition rather than a collaboration. Don't let the meeting drag on. Time box the activities. Don't delve on one idea too long. Don't allow mobiles and electronic devices. They are distractions. So what are the advantages of this technique? It promotes creative out-of-box thinking. Because it is informal, it is unstructured, and participation is encouraged, and there is no criticism, people are able to come out with creative ideas. It yields a large number of ideas in a very short time. And diverse experiences, strengths, and perspectives of members improves the richness and diversities of the idea. It encourages collaboration and team building and also consensus building. It builds up camaraderie and fosters a sense of buy-in, because people have been involved in developing the solution. They are more invested in it. It is a student-centered activity. While we are doing training, it's a student-centered activity. Students are generating their own ideas, developing rating criteria, and are responsible for group dynamics. It supports learning in a relaxed environment, strengthens problem-based learning, and it boosts group morale as well as individual confidence. When people get to talk, they become more confident about themselves. But yes, it does have certain disadvantages. Though it's a very good technique, it can have some problems. It requires a facilitator. Unless well guided, it can turn into a disorganized free-for-all. Some participants are more quiet and don't like to speak spontaneously in groups. Some participants need longer to understand the theme and cannot immediately provide idea. They need more time. Ideas may overlap or be unworkable. If there is no time limit, it can go on for hours, even days. Sometimes, like when everybody is generating ideas and you are listening to other people's generate idea, it is difficult to think of ideas of your own. So that can be a problem also. And a group think can trump independent thinking. Sometimes teams get too focused on a single idea, losing their individual sense of creativity. So that can also create a problem. Its very democratic nature can lead to stalemate. So if people can project ideas, they can also reject ideas. So that can cause a problem because they may not agree, the consensus might not be reached. And of course, it is not useful if it is not followed up by action. Thank you. So
if you stop sharing the screen, then we can.
Okay, just a second. I'll need to know how to do it.
You can see two buttons. Stop sharing with the red mark.
Actually, I have minimized my screen for Zoom and I don't know how to enlarge it. Just a second. Give me a.
Sure. You can take help of your.
And meanwhile, may I tell you one very stupid use of the green ball? It can be used to make your bun look thicker.
Sorry,
I had another idea. I had another idea.
Okay.
That you can cut a slit into it and make it use it as a piggy bank.
Yes.
See, this is how sometimes ideas come even after the activity is over.
Yes. So have I been able to stop screen sharing?
Yes.
Yes.
Thank you so much, Dr. Tanu. I think it was a wonderful presentation, to the point, and it generated a lot of good ideas how to use brainstorming in a very structured manner. And you really talked about the advantages, disadvantages, do's and don'ts in detail. So I'm sure this will stay with all of us. And whenever, not only for the communication program, even for your quality implementation or any management issues, this is the best way to engage adults, I feel. If you want them to, implement something, engage them in planning, and they're with you. And then, of course, if you can create an atmosphere where people can come out with their thoughts and ideas while maintaining the decorum of the program or session or meeting, it's a wonderful way. Design thinking is based on this concept of brainstorming. So it's believed that everybody who is part of the meeting has equal, right and equal ability to give their ideas and share their thoughts. And there it is used. And if you saw that 2 minutes video, there were only 5 participants.
Yes.
And I think around 30 ideas came up. So
yes.
that means
and very unusual ones too.
Yeah.
Just
although
as this one that you can cut a slit and use it as a piggy bank.
No, I was talking about the video that you showed.
Okay.
That there were 5 participants and they came up with almost like 30 ideas.
Yes.
If you saw the sticky board.
Yes, there was a whole board full of them.
Whole board full of them. So thank you so much. Any questions about it?
Just one thing I wanted to say about this brainstorming techniques. Actually, a lot of material, there a whole lot of more techniques. And I thought if I went into that, it will take over the presentation. But on net, a lot of techniques are available. There's a lot of work that is happening on it. Yes.
Absolutely. So true. Thank you so much, Dr. Tanu. So can we have presentation by Dr. Preeta, please? Unmute your device, please.
Yeah. Share screen I have?
Yeah, I have.
Okay. Is it showing?
Not yet. Not yet.
Now?
No, not yet.
Okay.
I was helped by my son
I
in doing
know.
the, projecting the things and all.
I know it. You require their help seriously. And it's so good to have them on our side. Yes, Pritaji, we can see your.
Okay. I think as we are getting late, I will be a little quick. It's already 10:30.
I know.
So it actually I was going to begin with this like, okay, now let's decide, think, if you had to take an interview for your position, what would be the question you would be asking the candidate?
So can you go to slideshow, Pritaji?
Yeah, one sec. This one?
Yeah.
Is it okay? Yeah.
Yes, fine. Yeah.
So what would you be asking? Just, I think we'll have response only from 1 or 2 people as we're getting late. If only 2 or 3 people can just, it's just fun game. Okay, just think you're interviewing somebody for your position. You are in the interviewing seat rather than the hot seat of answering the question. So what question would you be asking?
I would ask how many times you have failed and what have you done to come again.
Okay. Anuradha? What did you answer?
How would I answer? Oh,
what would
okay.
you ask? Somebody has come to take your position, and you have to interview them.
So I'll ask that candidate, how do you think you can replace me? What are your qualities?
Okay. Anybody else wants to answer this?
Educational and work experience.
Okay.
I
Anything
would
else?
probably ask, what strengths would you bring to the organization?
Okay. Anything else?
Purpose to join.
Okay. So while we are doing this, what is happening between all of us? I'm asking you questions. You're answering the answers. You are just thinking what it is. You are interacting. We are not physically. We are this. We are understanding about each other. So what is happening between us?
Communication.
Okay. And
exchange of thoughts.
Okay. So this technique, I have put it as a part of the ice breaking activity. Okay. So do you think this can work as an ice breaking activity?
Yes.
In an organization where there are juniors and seniors sitting together?
Probably, if they're juniors and seniors, it may not, because people would be very, but also on the other hand, it might, because, you are putting yourself in each other's shoes, basically. So,
yeah. So that is the whole idea of ice breaking, getting to know each other, right? The ice breaking is a form of activities which is a part of many training programs, which is a part of many things where people are getting to know each other. People use it in many different ways. Yeah, it could be any interesting activity, game, or conversation. Basically, it's a warming up thing where people get to know each other. So we have, you just start a training program, you do it in the middle of a training program. There are many things. There are advantages are you establish a friendly and good start to the program. You put participants, you get in a positive frame of mind because you start playing. There are many, this is just one at done. There are so many other ways to do it, passing the parcel and then do an activity. How many we've even done it in elderly training programs, truth or dare. So many, there are many ones happening. So when ice breaking also lessens the anxiety of a training program, because you're maybe walking in a room full of strange people. So ice breaking gets you to know each other. It helps in relaxing and acquainting the audience with each other, unknown participants to relax. That is the biggest advantage, according to me, of an icebreaker. Then the disadvantages, I feel it could set a very frivolous mode. Like if we had gone on with this for longer and I would have dug deeper and just prodded you all more, it could get into frivolous mode. It could become a time waster if it is not handled well. And it could lend the training not being taken seriously. The whole motto could be lost if the icebreaker is not done correctly, which is very important because it's a very delicate pedagogy, according to me, when you're starting off in a new group. So that's what. The do's and don'ts are, of course, the do's is always make it simple, keep the interest going. When you're circle of people, you don't move around the circle. You have to break the pattern, one here, one there, where you don't go very predictable. You cannot be. You need and if it's a big group, you divide into groups so that it doesn't become there. The don'ts would be you do not make people touch each other. I think that physical part has to be completely avoided in an icebreaker. You do not let anyone be humiliated. There can be some kind of games in truth or dare kind of things, or in thinking, okay, you take your senior's position and start doing something, or something like that. Then the office jokes set in, and the humiliation part can come in. We do not make it long because the purpose is lost, and we cannot force people to participate. If I'm coming to you and you don't want to answer, I try to move to the next person because I have to give you time to regroup your thoughts mentally. So that is very important. So this is it. It can be used as when participants come from different backgrounds and unknown to each other. They're the introductory icebreakers, I call it. Then where the different hierarchies are involved, the senior, junior icebreaking thing. Sometimes the icebreaking takes place in middle of a training program because a lethargy has set in. So you don't allow that to happen. When the purpose or topic is completely new, to introduce the topic, you start an icebreaker. And sometimes the trainer is so new to the team that the trainer wants to know the team. That time the icebreaker also is very much. So icebreakers can be used in a variety of ways. And and this is where it can be used. And I have actually done it a little quickly because I know everybody is getting late. But this is my presentation. Thank you so much.
That's okay. Thank you so much, Preeta.
Yeah.
Thank you.
Yeah.
So if you can stop sharing, then we can quickly wind up.
Yeah. Yeah.
I think the whole idea is that if you're using ice-breaking activities, actually, brings people closer. They open up, they start feeling relaxed. The barrier that we normally have of position or hierarchy or, geographical distance, that gets bridged up when you use these kind of activities. This was just one example of activity she gave, but then you have to be very creative in finding new interesting activities, but care has to be taken that it should not widen the gap, or it should not be offending or insulting or humiliating anybody. It has to be chosen very, very carefully. But I think overall the presentation was very good, to the point, and it gave us an idea that yes, ice-breaking activity, and especially where you think people are very monotonous and very quiet and not interacting kind, there this will really, really help you, because inhibition would go down, unknowingly, and then they'll open up with each other. Any questions about it, or anything that you want to say as a last comment? So I've shared the feedback form in the WhatsApp group. I thought, let me not hold you longer, but try to give it by, tonight before you sleep, if possible, because fresh you will be knowing. And the feedback is for the breaking of bad news and not of the presentation. Please remember.
Okay.
It was a good presentation. Thank you.
Thank you, ma'am.
Thank you so much. Bye-bye. Good night, everyone.
Bye.
Yeah.
Good night.
See you next Tuesday, 7:30.